Hello, I welcome you all in the lecture series of memory. As we have been discussing in the previous lecture on memory disorders, we tried to investigate and understand the root cause of memory disorders. There were two case studies which we discussed in detail, Henry Mollison case and Cleve, and we tried to understand what were the root cause of it. These two case studies gave us a lot of insight about the memory formation, the encoding, storage and retrieval problem. Now what we understand is that there are different types of amnesias are there, and sometimes the amnesia can be caused using the artificial drug administration, that is benzodiazepines. While going through all those case studies, we also understood that there should be other forms of interventions which may be leading towards the amnesia, and one such intervention is the ECT, electroconvulsive shock therapy. Electroconvulsive shock therapy, which is very good in the depression, however it leads to amnesia. The high amplitude of current short circuits the entire brain. As a result, the amnesia is a problem, though it is highly used intervention and very successful intervention towards depression, but eventually it results into amnesia. So we need a method where the loss of information should not be there, but the treatment can also be implemented. Now talking and taking this further down the line, we also discussed different parts of the brain which is responsible for the memory disorder. And one such part memory disorder is the frontal syndrome. Now when we talk about this syndrome, then multiple symptoms are there which is resulting, multiple symptoms from the frontal lobe are there which indicates the memory loss is there. And this we have seen in several cases. If you all remember the case of Finis Gage, the classical case where a mine worker just got a portion of frontal cortex removed, his personality changed, his other form of cognitive abilities also changed after the accident, after the trauma. So frontal syndrome, if we talk about, is characterized by the damage of the frontal lobe. Now we know that the entire brain is being divided into 4 different lobes: frontal, occipital, temporal and parietal. It is very important for us to understand that in this case the frontal lobe is the big region in the brain, and its projection and connection and dense networking with other lobes plays a crucial role in the memory formation, in memory retrieval and trace consolidation. Now when we talk about this damage to the frontal lobes, behavioral symptoms which include the retrograde amnesia, anosognosia and confabulation, where people try to create memories, fill the gap because there is a loss of information, and all these things has been seen. Confabulation is seen very commonly in the frontal lobe damage and in the case of frontal syndrome also. Confabulation also been seen in many cases like Korsakoff syndrome. Last time when we were having a discussion, we also discussed that how the confabulation is a common problem in these individuals, because due to chronic alcoholism these individuals do not remember the information for a while, and those information which they do not remember, they try to fill those gaps with some information. Source of amnesia has been an important concern here, and what we have understood from the empirical evidences that frontal lobe has been a major contributor in the memory, particularly retrograde amnesia. Retrograde amnesia, frontal lobe plays a major role. So when this happens, people forget the information prior to the incident or the trauma. But frontal lobe alone is not responsible in that regard also. One has to understand that the frontal lobe, whenever we are discussing the frontal lobe, then we have to consider 3 different types of brain regions: dorsolateral prefrontal cortex, medial prefrontal cortex and ventromedial prefrontal cortex, or orbitofrontal prefrontal cortex and ventromedial prefrontal cortex, and all these three brain regions are present on left and right. Now we know that it acquires new information. Frontal cortex is important in the consolidation of new information. Why? Because this is the primary site of information and is having dense projection and networking with the hippocampus. So frontal cortex and hippocampus, when it is being removed or when it is being damaged, then the initial loss of information, initial formation of information is also compromised. And also we have to understand that they also we have to understand that at the same time they also assist in the formation of new information, and whatever we have heard or recalled earlier is being compromised as well, which means that as we were discussing about the retrograde amnesia, anterograde amnesia and retrograde amnesia both are dependent on the frontal cortex. Some aspects of some specific types of memory such as the semantic memory and autobiographical memory is also being seen, because sequence of event which we are talking about, which is crucial in autobiographical memory, what should be the sequence of information, that seems to be compromised as well. Frontal cortex, as we discussed earlier, is a central executive system, and when central executive system is there, it involves phonological loop, visuospatial sketchpad all together, and it ensures the binding of information. So when we are talking about the frontal syndrome, these are the symptoms which we have seen. As a result, this frontal syndrome arises. Now what we also know about clearly is that as the initial new information formation is sometimes compromised, sometimes not compromised. So anterograde and retrograde both is dependent on the frontal cortex. Now here difficulty in organizing the events in the correct order also. So let us take an example. The easy example could be the Prime Minister of India, current Prime Minister of India, and the previous Prime Minister of India, and the Prime Minister of India at the time of independence. So if these three Prime Minister of India are there, then we have to organize this event accordingly, correct order. Like for example, we can also say arrange the age of the family member in an ascending order. So in that case we require the information about the age information from all the family members, and then whosoever is the younger, we start from there and then we go to the highest individual. This deficit includes also, as we have been discussing about, not only the arrangement but deficits also include the semantic and autobiographical. One has to understand clearly here that the deficiency or the deficit in the frontal lobe result mostly in the episodic memory, and semantic memory is being compromised because of the other association networking, and either one of these will be damaged or collectively both will be damaged as well. So the memory functions, the associated structures, dorsolateral, ventrolateral prefrontal cortex, dorsolateral prefrontal cortex, but the reward system is also being involved. Anterior cingulate cortex. This anterior cingulate cortex ensures the exchange of information, the reward system, punishment and reward. Now earlier we have been discussing that there are certain drug administration which leads towards amnesia and gives a scope to the researchers to investigate how exactly the memory formation is happening, how the loss of information is impacting the individual's day-to-day activity. And this amnesia is transient in nature, which means there for a very short duration, as the drug effect fades away, the amnesia is gone. But as long as the drug is there in the system and the administration of drug, from the point of administration, the individual face the loss of information. It is very difficult for the individual to store the information. Now, what we see here is that it's a rare form of amnesia where the amnesic effects are short lived, usually on the orders of hours. As the drug administration is there, the effect of drug is there, as it fades away, the amnesia trades off. So, if this is amnesia and this is the drug effect, so as the time passes by, drug effect will reduce and the this will be there. Just one second. So, this has to be drug effect and this will be amnesia. So, it also as the time passes by, so amnesia is there, but it is less. Now, when we are talking about the transient global amnesia, it is characterized by dense anterograde amnesia, which means that after the surgery or after the trauma, after the incident, people fail to form the new information, and that is been seen after the drug administration is being performed. It seems that the effect is there. So, as the drug level decreases in the bloodstream, the amnesia decreases. This is what we have seen. Now, even what we also know is that from the point of trauma, this is anterograde and this is retrograde. What we have seen that it is a dense anterograde amnesia is observed. So, till here, because the drug effect is still high, the amnesia is very dense in nature, but as we move forward, the effect anterograde amnesia decreases. So, there is no more loss of memory, which has been seen. TG patients may also suffer from retrograde from few hours to several years into the past, as we were discussing. Previously also we were discussing that there will be a loss of information up to 1 year. Though the retrograde amnesia is anterograde amnesia has occurred after the trauma, and retrograde amnesia is preserved, but still some amount of information loss is there. This some amount of information loss can be varied from few hours to several years, and that is what we have also seen in the previous lectures. The bodyguard of incident which happened with Princess Diana, he was able to recollect some information about the event, but few hours before the incident he was completely blank. He was not able to recollect the information. There is no loss of personal identity, what we have seen in this case, where the person remembers the information about his identity, where he lives, what he does, where he belongs to, all those informations are there. And also, but some aspects of cognition appears to be unimpaired and impaired. So, the cognition which is unimpaired is that if you ask the individual about some arithmetic problem or grammatical problem, then individual may respond towards it, because such amnesia does not affect his or her retrieval of long term information, but it seems that it affects the short term memory information. The short term memory information is at that present moment. So, the previous learned information seems to be unimpaired, but the short term memory seems to be impaired. It has also seen that the transient global amnesia tend to occur in people with middle age to old age, 50s to 60s, and then decreases among older adults. Now, there could be several reasons for this. Some people believe that it is due to the lifestyle. Some people believe it could be due to hypertension, Some people believe it could be due to aneurysm. So there are several examples and underlying causes towards it, and that is why it is not so clear what is the correct etiology of TGA, what is the clear underlying cause of TGA. So transient global amnesia, if you try to understand why it could be there, then some people have suggested that it could be disruption of the blood flow within the brain. So from the brain to the heart, any form of blockage may result into this transient global amnesia, and once this blockage is cleared from the brain to the heart, then the amnesia fades away. So if there is a temporary disruption is there from the flow from the brain to the heart, it results into ischemia, and as a result to this there is an amnesia. Sometimes compression of veins are there, preventing the proper flow of blood from brain back to the heart, and also has been suggested potential cause towards it. So this simple blockage, if the brain and the brain stem is there, so the blockage, the flow, the blood flow seems to be the underlying cause of it. Any pressure, any exertion on these blood veins, because these are very thin, they may result into the amnesia. As the pressure gets released, the amnesia fades away. Now, however, it is still not so clear that it could be the underlying root cause. What we really understand with the amnesia is that long term memory in one case get affected, and in one case the long term memory is not getting affected, but the short term memory is getting affected. Now whenever the short term memory amnesia is there, then we see that person is incapable to form new form of memory, and this made researchers to understand what is the underlying cause of such amnesia. Amnesias are of different type, though we have started the classification with retrograde and anterograde, but since then we have seen that retrograde and anterograde exist, but along with retrograde and anterograde there is a frontal syndrome, TGA is there, transient global amnesia is there. Artificially you can create an amnesia, and as a result you can study due to the result of drug administration, which is highly common, and that is why many times individual recommend high potency drug should be avoided, because the side effect could be amnesia or any other form of cognitive disability. Now when we talk about the short term memory amnesia, and we are saying that the long term memory is affected, but in anterograde the short term memory seems to be impaired, long term memory is intact. So Chalice and Warrington in 1970 started their investigation and tried to investigate what could be the brain region responsible for amnesia. Of course, by this time we know that frontal cortex is an important region, hippocampus is important region, amygdala is important region, brain stem is important region. However, it is still unclear what are the specific brain region. So there is a case study which Chalice and Warrington studied KF, the young individual who met with a motorcycle accident. This KF who suffered from a motorcycle incident, what we saw is that there was a selective impairment of short term memory happened. His long term memory was intact, long term memory was intact, but what got affected is the short term memory, it got impaired. What we saw is that the individual was able to perform other type of cognitive task, retrieval of information, episodic information semantic information were correct, language problems were fine, comprehension, reading task were fine. However, he had difficulty in the digit span task. The digit span task, same digit span task, where we studied that the individual has to remember the digit which is going to be increasing in the order, and an individual has to remember the digit and recall. He just had to recall the series of numbers, and as the number increases, the individual has to recall these digits. A normal healthy individual can recall 7 plus minus 2. This we have discussed earlier also, the magical number. So in this digit span task, he was unable to maintain 2 digits. More than 2 digits, it was very difficult for him to manage. So there is two forms of memory which frontal cortex is dealing with, which we earlier discussed also. Phonological loop, visual spatial sketchpad. Phonological loop deals with the auditory memory, and visual spatial sketchpad is dealing with the spatial memory or visual memory. And in this digit span task, when tested in auditory modality, and 4 when tested with visual presentation, visual presentation was intact. He didn't have any problem with that. But his digit span task, where the auditory modality was being involved, seems that he was impaired in that. So his auditory memory, phonological loop, seems to be affected after his incident, while his visual memory was intact. So this was a unique case. If you all recall the working memory model proposed by Baddeley and Hitch, we were discussing about the visual memory, auditory memory, the buffer and the central executive system. So here the input which is coming from the auditory memory seems to be impaired. Extensive damage to the frontal lobe of the left hemisphere. So right hemisphere didn't have so much damage, but the left hemisphere, this side of the brain, got damaged. And the localization of lesion was Sylvian fissure, which is connecting the frontal and temporal areas, which separates the frontal lobe and temporal lobes. So this Sylvian fissure which we are talking about, is something which has got impaired. Now this is an area of the brain closely associated with language formation and processing. And now in the case of dyslexics, in the case of learning disability, Sylvian fissure seems to be an important brain region. Which is trying to separate these brain regions. So what we understand with the case of KF is that his short term memory amnesia was there, but in the short term memory amnesia, his phonological loop or auditory memory seems to be affected most. As a result, he was not able to perform the 2-digit task. KF deficit might have been limited to phonological loop with less damage to visual working memory. Visual spatial sketchpad was fine, but the phonological loop was having a problem. Now another form of amnesia which came into light was the reduplicative paramnesia. What is reduplicative paramnesia? In these case of amnesia, people seems to have places or location which have been duplicated. For them, the two locations exist simultaneously. What has been observed in this case, the patient agreed that the hospital room looked just like the one found in the hospital in their local city. when in fact they were in their local city. Though the doctor said that this is your city, this is your city hospital, and the vision which you are having outside is of your own city, but they deny this. They have this denial that no, this is not my hospital, this is not my local city, this is somewhere else, I am here for the treatment. Though patients agreed that the view out of the window revealed a view of the town just like the small city near his home, but the patient insisted that the hospital was a different one and the city as well. So this patient recognized the surrounding, patient can recognize the surrounding, but they lack the feeling of familiarity. So here the concept of familiarity came into existence. So when the person is familiar with the location, person is familiar with the place, but is unable to implement that information at the present moment, seems to have a problem with the familiarity. And as a result, this form of amnesia, we are calling it as a reduplicative paramnesia, because there is duplication of the two places. Now, so here traumatic brain damage. So Hinckebein in 2001 tried to investigate this two neurological deficits that may create the reduplicative paramnesia. First thing, damage to areas in the right parietal lobe. Now parietal lobe, where? Whenever we have to look for an object, where it is being placed, then this pathway we are referring as where, and this pathway we are referring it as what pathway. So where and what pathway plays a crucial role, and they are moving from occipital lobe to the parietal lobe. So what we see here is that creates impaired visual perception and visual memory. Now visual spatial sketch pad is giving an input to the central executive system, which is the frontal lobe, about the visual information. In the previous case, in the KF case study, we were talking about the auditory memory problem. So central executive system is not receiving an input from the phonological loop, leaving the VSSP intact, but here what we are seeing is that the VSSP is impaired, leaving the PL intact. So creates a feeling of well known places are not familiar. Familiarity effect seems to be a problem. It induces the experience that familiar places have something peculiar or different in nature. What is that peculiarity? What is that unique characteristics or feature which their places are having plays a crucial role here. And second part is the bilateral damage to the prefrontal lobe. So one part is talking about the parietal lobe, and then another part is talking about the frontal damage. But in the parietal we were talking about the right parietal, but in the frontal we are talking both sides, bilateral, both side of the frontal damage is there. So when both side of the frontal lobe damage is there, it may not be sending projection to the parietal area, temporal area, occipital area, and because it is damaged, so the projection is not there. Projection to parietal, projection to occipital, projection to temporal, all are damaged. So neither the inflow is there, neither the outflow is there. Both got impaired. Both got impaired. So this is actually resulting in the deficit and creating an illusion. This, another important part, prevents the individual from experiencing familiarity because of this circuit is unfamiliar or dismissing its lack as an illusion. So, there is no illusion. Researchers also talked about impairment of visual familiarity. So, visual familiarity is there because the projection from frontal cortex to occipital seems to be damaged. What we see in this reduplicative paramnesia is that the region frontal cortex or parietal cortex plays a crucial role, and in this case basically the visual memory is being affected rather than the auditory memory. Now, another form of disorder is there, the Capgras syndrome. Now, the Capgras syndrome is unique in its nature. When we were talking about the familiarity with places or location, here we are talking about the familiarity of the people, and in this patient have a belief that people have been duplicated, people have a clone, people are imposters. It occurs when the patient believes that his family or her family members duplicated and replaced by the imposters or robots, and this is quite seen a form of memory disorder. Capgras syndrome is associated with psychiatric problem and particularly in the schizophrenia, and here people become aggressive and also hurtful. It often occurs in the conjunction with the face recognition, prosopagnosia, where they face problem in seeing the faces, and they even many a time come up with the conclusion that the person whom they are sharing the house with, whom they are sharing life with, is an imposter, and after medication and treatment still this problem emerges out. So, there is no clear medication to Capgras syndrome or reduplicative paramnesia. After the treatment, it seems that these individuals seems to have the similar memory problem after the effect of medication is fades away or the medication stops. Capgras syndrome arises breakdown in the connection between the temporal lobe areas, and so temporal lobe area when we were discussing about it, and the limbic system involved in emotion. Now, the idea here one has to also understand is that this syndrome, they even observed not only limited to people, but some patients seems to have extended this from people to animals also. So, the individual was also having a problem with his cat. Now, a 73-year-old man was suffering from retinitis pigmentosa, which left him nearly blind, and the Parkinson's disease, and was suffering from Capgras amnesia. He was suffering from visual hallucination at the age of 71. Strange people approaching his wife, meeting his wife, and might have replaced his wife, and even he believed that his wife was being replaced with men and women who dressed to impersonate her, who tried to take the identity of his wife, and he is living and sharing his life with the person is not his wife. He believed that he could always tell the difference between his wife and the imposters. When the effect of drug and when the treatment was okay, but after the effect fades away, then it seems that they were again having the similar problem. Various changes to medication were made, but no success. So, till date there is no effective treatment towards the Capgras amnesia or redistributive amnesia. Brain scan revealed minor scattered damage in the frontal lobes, but nothing is measured. Nothing is measured. Now, the question which arises is that this frontal lobe which is there, and it seems that it has been divided into 3 regions: DLPFC, OFC and VMPFC. All the 3 seems to be a major contributor and sending projection to different parts of the brain, and same time receiving projection from different parts of the brain. So what have we studied here? We tried to understand these symptoms, several symptoms resulting into the frontal syndrome, and in the frontal syndrome we understood that the phonological loop, visual spatial sketch pad and retrograde amnesia seems to be a problem, semantic memory problem, autobiographical memory problem, arranging of events is a challenge, which all of these things result into frontal syndrome. We also understood the new memory formation may not be affected that much, but the retrieval of old information may be affected. However, in some cases we have seen that the formation of new information is also affected, leaving the retrieval of old information intact. We discussed about the transient global amnesia, that its effect is transient, and the etiology of transient global amnesia is still not clear to us. It could be because of ischemia, or it could be because of aneurysm or any blockage or disruption which is happening in the blood flow from brain to the heart or vice versa. Short term memory amnesia, we understood that the anterograde amnesia is basically the problem after the trauma has been arised, after the trauma has occurred. The anterograde amnesia and retrograde amnesia, and what we are talking about is the formation of new information is affected, leaving the long term memory intact. And even when we are talking about the short term memory amnesia, we were also talking about the case study of KF, where he was able to, seems to have affected his phonological loop, auditory memory, leaving the visual spatial memory or visual memory intact. And then we talked about the reduplicative amnesia, where the people are having familiarity problem, the places and locations seems to be duplicative in nature and coexist. Then we discussed about that this reduplicative amnesia, which is talking about the places and location duplication, people similarly have extended this and have a problem with people amnesia. So a group of patients, sometimes they also have a syndrome where they seems to duplicate the people, which we discussed, that the 73-year-old man who believes that he is with his living not with his wife but an imposter, and this is a major challenge, and this is also a problem which has been seen in the schizophrenia. Now, after having discussion with these memory disorders, in next class we are going to discuss little bit more about memory disorder, and then we will end this session on memory disorder in the lecture series of memory. So see you in next class. Thank you for your attention.